Well, thank you, Sumit, for making me part of this CME program. The topic given is on DMEK graft insertion, tips and tricks. I have no financial interest to disclose. Now let's look at this. Is quite an old video of my initial DMEK cases. So the fluid-based delivery of the donor graft. This can be quite a stressful moment when you're trying to get the graft into the eye and the eye is trying to push the graft out. And then you have to manipulate. So how can we avoid this scenario? So there are a variety of injectors that are currently available. They are made either of glass or plastic, the IOL injectors, and they're made from various companies, like you have from Goiter, from Dork, from Corneal, the Endoglide. Some of the simple injectors which can be made, this was the one that I had described back in 2015. You can use an Alcon cartridge with IV tubing set and a syringe. So basically you cut a piece of the tubing and you can attach the Alcon cartridge to it. So the length of the tubing is 2 to 3 inches from the tip. Take the cartridge and so one end of the tubing is inserted into the cartridge and the other end is attached to a 5cc syringe filled with fluid. So this is what the injector system was, and this was actually described in a paper that was published in 2014 in Corneal, and we did use it. So you can load the donor tissue from the tip. You can see that that's the stained DM that's been either from the tip, or we could also load it from the posterior side by attaching a small tubing to the tip of the cartridge, attach it to a syringe, and then try to load it from the posterior end, which is much wider. So this is good when your tissue is an older tissue and it does not really get scrolled very easily. Then you can try and load it from behind. So you can also create this from a Sensor 3-piece cartridge. I think a lot of us have been using this. Dr. Basak, I think, prefers to use this for all his cases. So you take the Sensor cartridge, which is for the 3-piece IOL, you break off the wings. And then you can attach a small piece of IV tubing to one edge of the cartridge, and you attach a syringe on the other side, and you have your injector that's ready. You can aspirate the donor screw from the tip, and that's pretty much good to go. The other one that we described, trying to make it out of a pipette. So this is something that we got. So you can, these are not very expensive. You can use a number 15 blade and snip off the tip, giving it a beveled edge. And then since the base was too big, we preferred to cut it out at one edge. And this can be attached to a syringe. So that's pretty much what the injector looks like. Again, loading it was pretty much like what we do with our current glass injectors. We load it from the posterior wider edge by aspirating it, and then we attach it to the tip. So this becomes your injector, which goes through quite a small 2.2 millimeter, or it can go through a 2.8 millimeter incision, and you can deliver the graft into the eye. And this is again an injector that's available from Joja Surgicals. This is kind of a similar in design to the DOC injector. So basically, you can load the graft from the posterior edge, attach it to a syringe, and this can be, used for inserting the donor into the eye. So that's about the different injectors. Loading, as I mentioned, that you can load from the tip. Just that if you're loading it directly from the corneal scleral rim, make sure that your nurse keeps replenishing the fluid till the graft is into the tip of the injector system. But if you keep it in a bowl, then you don't have the problem because there is sufficient fluid. Make sure that your syringe movement is free. If you use a syringe that's very tacky and has a sudden movement, and if you don't have control, what happens is sometimes the graft can come into the barrel of the syringe, and then you have to, you may be wondering where the graft has gone, and that also leads to more loss of endothelial cells. Loading it from the wider end, it's relatively atraumatic. You can aspirate from the fluid. The other way of doing it is, again, you can directly load the tissue by holding it with a forceps. Just bring it up by capillary action. It just slides into the, you can either do that from the posterior end, or you can do it from the tip. This I used to do long back, but now I've stopped doing that. But this is an option where you can do this if required. Now, insertion, the fluidics is basically such that when you inject the BSS, it's a closed chamber, so you get increased intraocular pressure. And if your graft has not yet been delivered into the anterior chamber, you get rise in pressure. And the donor scroll has greater space to move. So you can have leakage of fluid from the anterior chamber, either through the paracentesis or the main incision, and you can have a partial or total expulsion of the donor scroll. So how can you avoid this? And also, when you have greater amount of space in the anterior chamber, the donor tissue can take various configurations, as I'm sure Praveen will be showing in his next video when he talks about unfolding. The ideal configuration that we want is a double scroll configuration with the open end facing upwards. So we described this novel technique in a recent paper that we published earlier this year, where we try to achieve a donor scroll configuration, even when after you have loaded your donor scroll into the injector. So what we do is we pull the graft into the wider portion of the, and then we agitate the fluid in a to and fro motion. So as you are pushing the graft out, it opens up, and then when it re-scrolls, it can go into a double scroll configuration. So on an average, about if you do 4 to 5 times this maneuver, your graft will go into a double scroll configuration. The only thing is, if you have an older donor where the donor's DM does not have a tendency to scroll, you may keep getting a single scroll. You may not have the double scroll forming. Now, to prevent this, the donor graft trying to come out, we tried to do a unidirectional flow. So basically, we connect a AC maintainer to the anterior chamber. The flow is on. So the chamber remains deep. You introduce your tip of the injector into the anterior chamber. Then you can rotate the tip such that the open end of the scroll is facing upwards. Once you have done that, you can ask your nurse to stop the flow of the AC maintainer, and it can be disconnected from the IV tubing. And at this point of time, so the AC maintainer becomes an egress point of fluid from the anterior chamber. Now, as you inject the DM scroll along with the fluid kind of comes out of the AC maintainer. So that we verified by doing, while we were doing cataract surgery, we injected trypan blue, and we can see the trypan blue flowing out of the AC maintainer, which is disconnected from the IV tubing. So if you look at a video, you will find that the tissue tends to go in quite easily because there is no counter pressure from the aqueous. And when you are removing the tip of your cartridge, the tissue doesn't try to come out of the eye. And the chamber also gets shallow because there is fluid flowing out from the AC maintainer. And that ensures that your DM scroll maintains the orientation that it's. So this makes it easier for you to unfold, because as Praveen will show, that getting a double scroll configuration with the open edge facing upwards is the best configuration. So when you're injecting, you always try to see which is the open end of the scroll before you inject. This is again just to show you another injection. So we get the tip into the anterior chamber, then we rotate so that the open end of the scroll is facing upwards. You stop the AC maintainer, disconnect the AC maintainer from the IV tubing, and now when you inject, you see that the scroll just goes in, it doesn't make any other movement, and then you tap. This was a single scroll, but the open end, so the orientation is the correct orientation. So the unfolding becomes relatively easy. The other technique of insertion, loading and insertion would be the endo-in technique. So here you are tri-folding the tissue, with the endothelium on the inside, pretty much like an ultra-thin DSEK graft. And then you pull it into a cartridge. Maybe I'll show the video once again. So this is again, tip being inserted into the anterior chamber. Go with a microforceps. The AC maintainer is running very slow. And then you can just pull in the DM scroll into the anterior chamber. This is again a complex scenario case where that's how you load. That's the tri-folded DMEK graft. Use a microforceps, pull it into that's again a sensor cartridge that I'm using. And once it's in position, you insert, that's a Merocell sponge stick that we use to block the posterior end, break of the wings. So this becomes like a popsicle, and you get the tip into the eye, use a microforceps to get the tissue. So here the it's an endothelium on the inside. So in complex scenarios where you don't have enough working space and you want to do a DMEK, so you can use the principles of DSEK to do and complete this. You can see you just tap on the surface and the graft opens up. The orientation is usually maintained. That's the picture. It can also be, it's very useful in eyes with anterior chamber lens where you don't want to exchange the IOL. You can use the pull-through technique to deliver your graft. So this is in short about the donor insertion, loading and insertion in DMEK. Thank you. Thank you for your patience.